Welcome once again to 10 Minutes with Harry. We are currently having a series on the interpretation of the normal pacemaker electrocardiogram. And today, number 5, we'll be talking about biventricular pacing. In order to understand biventricular pacing, I have to go back and explain some of the reasons for why we do it, and then we will look at the electrocardiograms. Biventricular pacing is used and indicated for non-bradyarrhythmic, it's the only non-bradyarrhythmic indication for cardiac pacing, and involves simultaneous depolarization of the right and left ventricles. It's useful for symptomatic patients with non-ischemic congestive cardiomyopathy with an ejection fraction of less than 35%. Some physicians use it for ischemic congestive cardiomyopathy, but the results aren't as good. This is because we have essentially dead muscle from the infarction, and as a result of this, one cannot get any improvement in contraction patterns. The patients need a New York Heart Association Class 3 or 4. They have to have had optimally tolerated medical therapy, and the ECG shows a left bundle branch block. Let's discuss left bundle branch block. It causes ventricular dyssynchrony. What do I mean by that? Well, we have septal dyskinesis. That is, the wave of depolarization continues from the His bundle into the bundle branches. But with a left bundle branch block, it needs to go first through the right bundle branch and then causes septal depolarization and contraction. Then the wave of depolarization moves across to the left ventricle with late activation, so that the septum and the remainder of the left ventricle contract at different times. And this is essentially a swinging movement rather than a contraction. And therefore, this is a mechanical reason for why the ventricle does not contract. The echocardiograph shows paradoxical septal motion. We correct the dyssynchrony by pacing the left and right ventricles simultaneously. This is called cardiac resynchronized therapy, or CRT. How do we do it? Well, it's biventricular dual chamber pacing. The implantation technique involves an extra lead in the distal cardiac vein via the coronary sinus. And we can see below a coronary sinus venogram with dye in the coronary sinus. Once this is done, we can then find a suitable vein, a small vein, in which to insert the lead. And as you can see here with the red arrow, where we're going to insert it. And then once it's inserted, you can see it go down into this vein. We require a special pulse generator with 3 ports rather than the normal 2 for dual chamber pacing, an atrial port above, a right ventricular port, and then a left ventricular port. Here is an ECG of biventricular pacing. We can't see too much of it, so I will highlight some of the areas of interest. Firstly, V1 shows a right bundle branch block. You can see the stimulus artifact and the wide QRS, but it's a right bundle branch block in a patient who initially had a left bundle branch block. This is because for best results, we need to pace the left ventricle first, causing the right bundle branch block, and then a short period after that, the right ventricle is paced. The other feature is that we can see 2 stimulus artifacts on the QRS. Firstly, we can see the atrial pace. Then we red highlight here, you can see two spikes. The first is the left ventricle and the second is the right ventricle. Let us look at a number of tracings showing differences in the left ventricular to right ventricular times where we pace them. So if it is 0, that is both are together, one can see that it's really just a left bundle branch block appearance. Whereas on the right, we can see a right bundle branch block appearance when the spikes are brought out to 80 milliseconds, so that you can see the first spike and then the R wave, and then follows the right ventricle 80 milliseconds later. And in between 40 milliseconds, we can see a compromised situation that is in fact a right bundle branch block, but a much shorter distance between the left and the right ventricular stimulus artifacts. There is another form of left ventricular pacing, which is called multipolar. And you can see here an illustration which, when you highlight the area of V1, you can see that there appears to be a number of stimulus artifacts, and this has a right bundle branch block. So to the left, we can see atrial pacing and ventricular pacing. To the right now, we have a left ventricle spike. We have another, because this is multipolar, we have another one. So there are a number of poles on the single left ventricular lead. And then we have right ventricle. And this is multipolar left ventricular pacing. Another confusing ECG appearance is what I call biventricular triggered pacing. This may be VVT or DDI, and I'll explain those later. Here we can see the ECG, and we have biventricular pacing, but now of sensed events as well as paced events. A number of companies manufacture this algorithm, and it looks confusing on the ECG when you look at it, because all you can see are spikes going through all the QRS complexes. So let us highlight them, and we can see leads 1 and 2. And we now have, with the red highlight, a fully paced beat, and it has two stimulus artifacts, the left and the right. However, the yellow highlight shows a ventricular ectopic, and there are also stimulus artifacts within this, so that you can see two of them, the left and the right, but they occur well into the QRS. The objective is to try and pace the ventricle in patients who have frequent ventricular ectopics, so as to overcome the negative aspects of these ventricular ectopics. But because they are quite late, I doubt if they are physiologically important. Let's have a look then at this tracing, and we can see that there are pace beats, red highlight, and then we can see the ventricular ectopics, a couplet, and you can see how, or it's actually a triplet, and you can see how the stimulus artifact lies in the middle of the QRS and is unlikely to be physiologically important. But if we go now to where the, programmable, its default setting is on. That means that when it comes out of the box and is implanted in the patient, this type of pacing is turned on. It is energy wasteful, and it has suspect physiologic benefits. But remember, it's turned on, and therefore we will see it on the electrocardiograph quite frequently. You must turn it off if you don't want to use it. There is also an upper rate triggering limit, with the default being about 130 beats per minute. What do I mean by that? Well, if one has a run of atrial fibrillation that's 130, 140 beats per minute, you would find that this would be unsatisfactory if there were stimulus artifacts in every one of those QRS complexes, as it would waste energy significantly. So we do have an upper limit of about 130. And if one looks closely in this tracing with the blue highlight, you can see there's a ventricular ectopic, but there's no stimulus artifact in this because it exceeds the default setting of approximately 130 beats per minute, and therefore is not actually triggered, even though it is sensed. Let's have a look, therefore, at another ECG, and you can see a ventricular triplet. To the left now, we have atrial sensing and ventricular pacing, and the ventricular pacing is biventricular. Now we move on to the triplet. You can see the yellow highlight that the QRS is sensed and the stimulus artifact is in the middle of it. The next two, blue highlight, are not sensed because they are too early and beyond, and you can see from the blue highlight on the numbers that they are at a rate of 180 beats per minute. I've stated at the top that this can be VVT, as it would be with a patient of atrial fibrillation and biventricular pacing, or DDT, which means that there is dual chamber pacing, biventricular, dual chamber sensing, but instead of inhibition in the ventricle, there is triggering. And so we call this DDT, and we ignore, in this example, for the atrial inhibition that also occurs. So what have I learned? Biventricular pacing is useful therapy for non-ischemic cardiomyopathy and requires a left ventricular pacing lead. Usually the left ventricle is paced before the right. The ECG is showing a right bundle branch configuration and, of course, the two stimulus artifacts. Biventricular triggered pacing has two stimulus artifacts embedded in the native QRS, which leads to confusing ECG appearances. Thank you.